it's now become apparent that the host response biology is as important as the tumour biology when we start to design personalised treatment strategies. And by host response biology, what I mean is what the individual's biological function is, and can they tolerate the onslaught of clinical impact from myeloma, as well as the toxicities of treatment. And this is part of the treatment burden that patients face. And some people will think, well, that's just easy, it's just based on age. But in fact, it's not. It is about aging, that is true, but it's about accelerated aging. And that's where the impacts biologically of aging are driven by other metrics within an individual's life, such as comorbidity can drive that. And also myeloma itself can drive these accelerated aging phenomena. And this all stems from senescent cell burden and relates to body composition and the inflammatory program that is associated with aging, particularly accelerated aging. And what all of this does is it tends to drive our physiological performance associated with getting older, and it drives it quicker toward disability and frailty. And the consequence of that is you have an increased risk of infection, cardiometabolic disease, surgical complications, and of cancer per se. So when you take that knowledge base and apply it to myeloma, what it means is that we are going to look at patients in a slightly different way. These are patients who will be more susceptible to complications and toxicity. These will be patients who will not be able to tolerate treatment as well, and therefore not get the full benefit out of the modern evolution of myeloma care as the younger patient does. And we've seen this. We know the 5-year survival rate for patients over the age of 75 is significantly inferior to those under 75. And a lot of this has been driven by the host response biology. So how do we identify these patients who are at risk of being vulnerable to not only the treatment, not only the disease drivers of frailty, but also treatment burden as well? And Antonio Palumbo, 5 years ago now, published some seminal work that gave us the IMWG frailty score. And Terry Facon and colleagues, using the first trial data set, was able to modify this, replacing the functional assessments of ADL and IADL with a WHO performance score, and therefore the scoring system still held validity. And you're able to delineate people into being fit, unfit, and frail in that context. There's been a number of other attempts to try and improve or refine this, including our very own myeloma risk profile, which is based around CRP. Age as a continuous variable rather than a cohorted variable, as the IMWG has. And performance score along with ISS. And what these scores are doing is trying to highlight who is and who is not vulnerable. But it's a bit more complicated than that. I mean, these scoring systems are relatively blunt tools, and we need to try and refine these. Not only that, but what we don't know is how dynamic these tools are. For example, if you're a myeloma patient and you're presenting with myeloma for the first time, then you have myeloma-associated morbidity, as well as morbidity related to your general health, your host response biology. So when you add these scoring systems, can they delineate between those two fractions? Possibly not. We don't know. That investigation hasn't been done. So therefore, there is a need to be starting to think about other biomarkers of frailty and susceptibility. And this is an evolving area of research. My research group are particularly interested in looking at immune senescence, looking at immune senescent T cells in particular, but not only that, but senescent T cells that are either driven because of replicative senescence drive or because of DNA damage drive. And that might give us a differential between an aging effect versus a disease effect. But then we start to get into proteomics, and we're talking about inflammatory proteomics, again associated by senescent cell burden, but also being driven by the myeloma itself. and also the proteomics of body metabolism. And by that, I'm talking about the crosstalk between skeletal muscle and adipose tissue. And that is something that may well offer up a window of opportunity to delineate people vulnerability-wise. And then the last point to really raise is using imaging to define body composition. And by that, I'm referring to both sarcopenia and adipose tissue distribution. Changes from subcutaneous to visceral adipose tissue distribution, for example, can highlight patients who are at risk of cardiovascular disease, metabolic disease, infections, and cancer. So this is an area that's evolving in myeloma care. And again, we have some research work that is ongoing in this regard.